Thank you for inviting me to this meeting. Thank you, my friend Dr. Daniel Roche, for sending me the invitation. And I'm glad to be invited to talk about manual small incision cataract surgery and IOP lowering patients with glaucoma. My name is Dan Kiage from Kisii, Kenya. I have no financial or conflict of interest to disclose. So as we know, cataract and glaucoma are both leading causes of blindness in Africa. They often coexist. There is no clear guideline on the management for the coexistent morbidity. Over 90% of cataract surgeries in Africa are done by small incision cataract surgery. In terms of preference of primary open-angle glaucoma in over 50s, studies which have been done in South Africa show that it's about 3.8%. In Tanzania, it's about 4.2%, 4.6% in Kenya. In West Africa, about 5.8%. It does appear that there's an increase in glaucoma as you go from South Africa to Eastern Africa, going to West Africa. In terms of RP lowering effect of cataract surgery, there is positive, robust data, but a meta-analysis which was done by Fredman and colleagues, they were looking at surgical strategies for coexisting glaucoma and cataract. And there was weak evidence of lowering of IOP of 2 to 4% in both phaco, and that time they were using extracapsular cataract extraction, which is similar to manual small incision cataract surgery. And the conclusion is that there's a strong evidence of better long-term control of IOP with combined glaucoma and cataract operation compared to cataract surgery alone. Some other colleagues from Africa, this from the Congo, Dr. Nganga, did a study on IOP decrease after manual small incision cataract surgery, and he looked at 147 eyes and saw that 83% exhibited a decrease in IOP. The mean IOP was about 15 millimeters mercury. Post-op went to about 12 millimeters mercury, and there was a decrease of about 20%, and this was statistically significant. So in conclusion, this decrease in IOP, well known after phaco, was also obtained after manual small incision cataract surgery, a surgical technique which is increasingly employed in developing countries like Africa. Some other colleagues from Burundi, Nchirimana, looked at the effectiveness of temporal manual incision cataract surgery in chronic angle closure glaucoma. In their study, there was a baseline of pressure of about 28 millimeters mercury, and it came to about 16 millimeters mercury after 30 days. And interestingly, this is similar to the EAGLE study, which employed phaco, in which there was also a decrease from 29 millimeters mercury on baseline to about 16, which was similar to what the manual small incision cataract surgery in Burundi showed. Although it's difficult to compare these studies, the EAGLE took over 36 months, and the Burundi study was for only 1 month, and it was a chart review. But the important message is that the decrease in pressure was the same for phaco and manual small incision cataract surgery. So what do we do in Africa? What we have tended to do, and this is a video which was shared to me by my colleague Cropsy, and it's kind of promoted this, and most of us have started doing manual small incision cataract surgery from making a temporal approach routinely. And it's got many advantages. Obviously, it's got the advantage of decreasing the against the rule astigmatism, which is prevalent in this age group. But as far as glaucoma is concerned, it also lowers pressure, as has been shown in some of these studies. But being glaucoma specialists, we should actually all try to get paranoid in touching the superior conjunctiva, because this is where, with so much glaucoma in this region, you really want to preserve it in case at some point you're going to need that conjunctiva to do some procedures like trabeculectomies or tubes or any other procedure that you may want to do from there. So, so although there are some opponents of this procedure, it's supposed feel that it could be increasing infection, although no studies have really demonstrated that there's more infection in having a temporal approach. And it's true that maybe it's got a little bit of higher learning curve, steeper learning curve than the superior approach. But if one trains well and if one picks the technique well, it has so many advantages. And so if you're a good small incision cataract surgery, one can recommend that you change to temporal so that you can spare the conjunctiva above, especially in Africa where glaucoma is so prevalent, and to also have the advantage of again a cellular stigmatism. So most of my colleagues are doing this more and more, and I guess it's something that we could wish to promote. And Dr. Cropsey has been talking about this in conferences in Africa, and a lot of people are changing to doing temporal small incision cataract surgery. And being paranoid about the superior conjunctiva is something which I think every glaucoma specialist should be. So, so in conclusion, going ahead, of course, this is what we do, but we all know that both cataract and glaucoma are major blinding diseases of great public health importance. Manual small incision cataract surgery is a major method used in Africa for cataract surgery, and manual small incision cataract surgery does play a role in the management of glaucoma by lowering IOP. Thank you.
Greetings from Malawi, Southern Africa, where I'm presenting from. My name is Dr. Kumbo Kaluga. I am an ophthalmologist based in Malawi, Southern Africa. I am also the director for the Blantyre Institute for Community Outreach in Blantyre, Malawi. It is a pleasure for me to present here at the NMA 2023 convention here in New Orleans. Due to other reasons, I could not be available in person. I'm going to be presenting about elimination of trachoma as a public health problem in Malawi, Southern Africa. Presentation layout. Background on trachoma as a blinding eye condition. Success in the trachoma elimination program using Malawi in Southern Africa as an example. Summary and acknowledgements. Trachoma blindness as a public health problem. Trachoma remains the leading cause of infectious causes of blindness globally as a clinical entity. Trachoma infections is caused by Chlamydia trachomatis, which is transmitted by flies. The World Health Organization has come up with a simplified grading of trachoma for field work. And as you can see from the slides that I'm projecting, this is a slide of elevated eyelids. Slide A, this is when you elevate the upper eyelid, you see trachoma follicles. These are 5 or more round nodules on the upper tarsal conjunctiva. This signifies that there's trachoma infection, active infection. On slide B, this is where you have got concentrated inflammation as well as infection, such that you can no longer see the follicles. This is called trachoma intense or TI. Slide C, this is when the trachoma has been going on for a while, the infection. As a result, it has started causing the scarring of the eyelid as part of the healing process. And that scarring is clearly seen on the upper tarsal conjunctiva. It is known as TS. And slide D, This is when now we start getting worried about blindness. This is when you have now the entropion, or the upper eyelid turning inwards, where the eyelashes start rubbing on the globe, either on the cornea or on the conjunctiva, and this becomes very, very painful for the ones who have got trachoma. They get excruciating pain because of the eyelashes rubbing on the cornea or the globe. And finally, slide E, this is where there has been intense rubbing of the tracheasis on the cornea, such that the cornea eventually became opaque, and this causes irreversible blindness. Trachoma is responsible globally for loss of vision or blindness in over 1.2 million people. And the sufferers, indeed, they suffer a big burden because of this disease. Eliminating trachoma as a public health problem. The World Health Organization established in 1996 to fight trachoma through what is called GET 2020, or Global Elimination of Trachoma. And an elimination strategy was endorsed by the World Health Organization, where you are supposed to do 4 things: surgery for the people that have got tracheasis, or the eyelashes are rubbing inside, to elevate the eyelids back to the normal position; antibiotics using azithromycin to treat the infection and reduce the disease transmission; face washing, as its dirty face that is associated with the transmission by the flies; and environmental improvement generally to also control flies. This strategy is called the SAFE strategy. A number of ophthalmologists have been involved in the trachoma surgical management control, either through the surgery, oculoplastic surgeons, training, certification, or quality assurance, or like myself, through program delivery, supporting teams, paramedicals, and all that to deliver public health programs that can eliminate trachoma. Progress towards trachoma elimination in Malawi. Malawi, as I said, is a small country in southern Africa. It's one of the poorest, with 19 million people. And blinding trachoma has been a problem since 1983, but it needed a well-coordinated effort between the ministries of health, the donors, and the implementing partners to be able to eliminate this disease. Implementation of the full SAFE strategy was started, and between 2015 and now, over 6,000 surgeries were done through the program. These are 6,000 surgeries with people that had tracheasis who are potentially going to get blind. The trachoma race in Southern Africa had 4 countries: Tanzania, Zimbabwe, Zambia, Mozambique, and Malawi being the 5th one. And it is only Malawi that has managed to control the trachoma, despite all the countries having millions of dollars supported to fight the trachoma. So lack of funding was not a major issue in the trachoma program in all these countries. So how did Malawi get there sooner? Well, there was a guidance from the World Health Organization. The partners came together to strengthen the national capacity, and they started coordinating with funders. And then we had the committed donors: Pfizer, who was donating the drug azithromycin, and ITI, International Trachoma Initiative in Atlanta, who was assisting the countries in distributing the drugs. And then each country had the national action plan, and then there was advocacy at the highest level. There was also strong leadership from the ministry, and funding from the Queen Elizabeth Media Trust, and SciSafe as a coordinating partner, and other partners included BICO, CBM, Amref, WaterAid, and a team of committed ophthalmologists and committed well-equipped survey teams. So what was so special about BICO's involvement? Who is BICO? BICO is an NGO or a charitable organization that I started about 15 years ago in dealing with eye health issues at the community level. And it just happened that at this point, BICO was one of the partners that were available to mitigate in the trachoma. There was a challenge that there was limited capacity to conduct nationwide service, and BICO became that partner to conduct the service. And there were also limited implementers. Everyone was busy, as we are with ophthalmologists, and BICO volunteered to assist. And there was limited time, and BICO was there to assist with all the programs. So this is the team that I organized with the Ministry of Health, who gave us vehicles, and we were able to go throughout the whole country to do the surveys and the mapping. As a result of that, the government formed the National Trachoma Task Force. We mobilized resources. We started giving interventions in all the districts, including medicines as well as surgeries for the 6,000 people. And we conducted over 180 surveys with over 100,000 people examined in the field for the eye examination to rule out trachoma. Here, as you can see, even when there was COVID, we still went ahead with full PPE and in the rain. And there was advocacy at the highest level. We had visits by the member of the royal family in the UK. BICO started organizing regional meetings for the trachoma. We had the first trachoma expert committee meeting in the Southern Africa. And here you see the Minister of Health and the Permanent Secretary with the team of BICO, with me in blue there, coordinating about the trachoma. What were the effects of this intervention? Well, as I said, we operated on 6,000 surgeries. We implemented all the safe strategy. And after that, we went ahead to do the surveys, and we found out that trachoma had been eliminated. The surveys that we conducted in 2021 showed that all the areas in Malawi had eliminated trachoma. So this is a map that we started with in 2013. You can see that where it's green, that's where it was clear, but the rest of the area of Malawi map was not clear. But then you see in 2021 that all has been cleared, showing that indeed trachoma has been eliminated as a public health problem. Following the elimination of trachoma, we submitted a dossier to the World Health Organization, asking them to certify that Malawi had eliminated trachoma. And indeed, on the 21st September 2022, the World Health Organization validated Malawi for eliminating trachoma, and this is the first country in Southern Africa that has eliminated trachoma. Here is the validation certificate from the WHO, signed by the World Health Organization CEO, Dr. Tedros Safe. And just to inform you that trachoma elimination remains a challenge in the African region, with only 4 countries, Ghana, Gambia, Togo, and Malawi having eliminated, and 7 other countries still fighting for trachoma, and people going blind as I speak now. The Queen Elizabeth Benjamin Trust, in recognition of the good work that the Blantyre Institute for Community Outreach, or the BICO that I was coordinating, led the work, gave us a recognition which was given to me on behalf of the Malawians. In addition, I was privileged to be invited to the Buckingham Palace by Her Majesty the Queen to witness the elimination of trachoma. May her soul rest in peace. Many other partners, including members of the IAPB, the ICTC, the ICO, the ITI, contributed to the success of the trachoma program in Malawi. And indeed, it has been an opportunity for the NMA to allow me to present this success story to Malawi and the success story to the whole world. Success is best shared when it is shared together. As I wind up, I would like to say that there is an opportunity within the global eye health to do global eye health programs, so that we as ophthalmologists, we must think outside the box and be able to contribute globally to blinding eye diseases like trachoma. I would like to thank the partners that supported us, which included the Queen Elizabeth Trust, ICTI, London School, ITI, Ministry of Health, CBM, and many others to mention. Thank you very much for this wonderful opportunity. Thank you.